We're going to get started right away. And just a reminder, we have our phenomenal visiting professor for our CFAR seminar following this talk, along with a CFAR Excellence Awards. So lots to come in the next couple of hours. I want to welcome Dr. Franco Chevalier and Dr. Oliver Bacon here from the San Francisco City Clinic to share two fantastic topics related to sexually transmitted infections in people living with HIV. Dr. Chevalier will start, and he is the Deputy Medical Director of the San Francisco City Clinic, followed by Dr. Oliver Bacon, who is the Medical Director of San Francisco City Clinic, as well as an Associate Professor of HIV/ID Medicine, our Division of HIV/ID and Global Medicine. So without further ado, let's give them a warm welcome, and thank you for being here.
Thank you. Thank you. Good morning to everybody. As Aisha alluded, we are going to be presenting some cases and talking a little bit about some of the hot topics from the sexual health perspective at San Francisco City Clinic. So I'll be exploring the topic of urethritis a little bit at length and talking a little bit about some of the specific things that we do at San Francisco City Clinic. And then Dr. Oliver Bacon is going to be talking about doxypep and some of the findings and interesting things that we see at San Francisco City Clinic. So without further ado, I'd like to sort of explore urethritis with a case that we actually encounter at San Francisco City Clinic. These are my disclaimers right here. As far as our case, this is a 35-year-old MSMW that presented with complaints of dysuria without urethral discharge. And the patient also noted some itching, irritation around the urethral meatus. And as far as a little bit of the sexual history, this patient attributed having sex with men and women, and their last encounter prior to coming to us was 7 days with a male partner. They engaged in anal insertive and it was unprotected. For the last 3 months, he reports having sex with 5 new sexual partners, had negative STI testing 2 months ago, and that's for GC, CT at all sites, as well as syphilis. The patient is actually on PrEP 211 and is quite adherent and covers all of his sexual activity with PrEP 211. And today he's interested in doxypep, which Dr. Bacon will talk about later. On exam, however, he has no urethral discharge, no lymphadenopathy, no penile, testicular pain or swelling. Given that there is no discharge, we obtain a urine and we spin it. And the urine microscopy actually reveals that he has greater than 10 WBCs per high power field, no bacteria, no red blood cells, and no yeast. The urine is actually sent for GC and CT, and that's currently pending. And so given the greater than 10 WBCs on urine microscopy, we give him the presumptive diagnosis of non-gonococcal urethritis. And for that, he gets doxycycline 100 milligrams PO BID for 7 days. This is just a picture sort of showing what WBCs look on urine microscopy, which we have the capacity to do at City Clinic. You can see that's a white blood cell, and that is a red blood cell right here. So a little bit more about the case. A week later, the patient's symptoms aren't changed despite the completion of the doxycycline. He actually goes to urgent care, and the workup is significant for positive leukocyte esterase, but negative nitrites. So they presumptively think maybe this could have been a UTI or something, but doesn't seem that way. He denied any more sexual activity since the diagnosis and reported full adherence to the treatment. But now you're concerned that this patient potentially has persistent urethritis at this point. And so I'd like to ask a poll question. In addition to confirming that the patient took the doxycycline and was completely adherent to the therapy and that their partner was treated, would you do any of the following here? Let's see if this works. I'm not sure. I'll just give it a quick second. Interesting. All right. I like to see that there's like a split in the answers, because I mean, in technicality, none of these treatments necessarily are completely wrong, and nobody will fault you for wanting to choose one over the other. And so that's something that we will talk about and stuff. But it's interesting to see that majority, at least, of people that voted will give macrobid for 7 days for potential UTI, given the negative nitrites on the urine dipstick. But more to come on that. So I like to sort of segue a little bit and talk a little bit about non-gonococcal urethritis, or NGU, how we typically call it. And this is just inflammation of the urethra that's caused by pathogens other than gonorrhea, and generally transmitted through oral, anal, and vaginal sex. Symptoms, however, may vary, and they can be quite mild, but also quite debilitating. And they can encompass things like dysuria, mucoid or mucopurulent-like urethral discharge, sometimes purulent, So don't be fooled by gonorrhea. It's not the only thing that will present purulent. And also erythropruritus in persons with a penis. The diagnosis generally, if there is the presence of actual discharge, will be done through a gram stain, looking for WBCs as well as gram-negative diplococci in the context of gonorrhea. And generally speaking, we will send for GC culture as well, just to make sure that we are not missing gonorrhea, because microscopy is only 70% sensitive at times in order to be able to actually diagnose it. Now, if the discharge is not present, we generally look at the urine, and we generally do a urine dipstick and look for the presence of leukocyte esterase. And if that is negative, then we generally do microscopy of the urine for the presence of WBCs, if available. And like I mentioned, if greater than 10 WBCs per high power field, then that automatically gives you the diagnosis of NGU, or by definition. Now, some of the most common causes that I sort of alluded by asking that question about what would you do, actually include all of these organisms here. 15 to 40% of the cases of NGU are generally, the culprit usually is Chlamydia trachomatis. And obviously this presentation, or this percentage, actually varies by age group depending on the population that you're dealing with. Mycoplasma genitalium actually can be quite present in 10 to 25% of the cases, and it's actually the second most common cause. Obviously, there's enterobacteria for those individuals that engage in insertive anal sex, Trichomonas vaginalis for people, for persons with a penis who have vaginal sex. And then on occasion, but quite rare, I think I've only seen one HSV case so far at City Clinic. There's HSV types 1 and 2, EBV. Adenovirus has been attributed as well as Haemophilus influenza, although as I mentioned, there are quite less common causes. Now, Mycoplasma genitalium, which I sort of want to focus on for the context of this particular talk today, also known as MGen, and you may see me referred as MG on the PowerPoint today. It's a bacteria, and it's known as a molecule because it lacks a cell wall. It is generally an intracellular organism, and it is quite slow growing and difficult to culture. It can take up to 6 months for the labs that have actually been able to isolate it, and it can cause an array of different things, as you can see here, which can sort of hint at the fact that someone might have GC or CT. Things like cervicitis, PID, infertility, urethritis, prostatitis, and even proctitis, which we've been able to diagnose at City Clinic in the context of having all other negative tests. MGen has come back positive in some of our rectal swabs as well. And generally after treatment, patients do quite well and recover. Now, as far as the prevalence of Mycoplasma genitalium in STI clinics, there was a study that actually looked at the prevalence in asymptomatic individuals. They actually looked at samples that were sent out to the lab for GC and CT, just to kind of look and see what the prevalence of MGen was in the population. And as you can see here, it kind of varies quite a lot, from 9% all the way to like 20% in asymptomatic individuals. Now, I'm not encouraging people to obviously go and screen asymptomatic individuals, and we'll talk more about that later. But this is just for you to know that it is quite prevalent, and it is present, and it's something that we should be thinking about. And so with that, I'd like to ask another question. All of the following STIs we know increase the risk of HIV acquisition in cisgender women. Now, which of these confers the greatest relative risk? And I'll give it a quick second. And I have a suspicion that maybe people will know what I'm trying to allude to here. Very interesting. Right, I like it. Someone is to pick number one too. Just kidding. But yeah, so essentially what I'm trying to get to here, and I appreciate all of you guys voting as well, is that there was actually a study that looked at the breakdown of HIV acquisition among women and also MSM. And they were looking at to see which of these infections actually was attributed to have a higher risk of HIV acquisition. And as you can see depicted on the blue box here, Mycoplasma genitalium actually demonstrated a threefold increased risk of HIV acquisition among women, as well as MSM with untreated MGen infections. So although all of these actually can have impose an increased risk of HIV acquisition, it was pretty interesting to show and demonstrate that MGen actually is the one that has the highest risk. Now, who should we be testing? Obviously, we don't want to be testing asymptomatic individuals. However, the CDC actually recommends that people with symptoms or signs of persistent and recurrent urethritis and cervicitis who fail initial treatment should be should be tested, as well as individuals that present with complaints of PID. Also, contacts to patient with a non-confirmed case of MGen, and they also are very explicit about the fact that we do not screen asymptomatic individuals. Now, at San Francisco City Clinic, we like to do things a little different. I kind of feel like we are like the little rebel child sometimes, but we do test everyone with urethral or cervicitis symptoms for MGen at initial presentation. And so rather than waiting for persistent or recurrent urethritis, we actually send an MGen swab for individuals, an MGen testing of the urine as well for those individuals. And I'll tell you why a little bit more. But before we get to that, just to kind of highlight a little bit of the treatment and the STI treatment guideline updates from 2021, the treatment for Mycoplasma genitalium, it is a sequential treatment process for suspected and documented MGen cases that usually consists of doxycycline 100 milligrams BID for 7 days, then followed by moxifloxacin 400 milligrams daily for the next 7 days. In the past, azithromycin was considered to be sort of like the state of treatment. However, that is no longer the case. And they do have some explicit guidance in terms of macrolide resistant testing, which if it's not available, generally doxy-moxy will be the way to go. And most places, including us, do not have the capacity to do macrolide resistance testing. And therefore, we do not recommend doxycycline to azithromycin treatment, but doxy-moxy. Now, something that's really important to note is a big question that we get is how long should we wait or how long is it okay to wait to start the moxifloxacin? As we know, if a patient presents to the clinic with NGU and they don't have a documented diagnosis of MGen, they may not necessarily come back right away for the testing. And so if a patient is taking doxycycline, it is okay if it has been less than 7 days since their last doxycycline dose to then follow up with moxifloxacin daily. But anything over 7 days, the treatment should be restarted. Now, if someone does not get better, they should be retested. However, as far as testing goes, retesting is generally considered to be after 3 weeks in order for false positives to be completely out of the window. And the reason why is because there is a really high risk of false positives for individuals that come and get retested for less than 21 days. And so it's really difficult to interpret whether or not this is a new infection or whether or not this is still ongoing from the previous infection. The other thing to keep in mind, and part of the reason why macrolides are not necessarily first line any longer, is because, as you can see, macrolide resistance throughout the US has actually been on the rise. This is again referencing back to that study where they were looking at asymptomatic individuals from GCCT and findings of MGen. And what they actually found is that resistance to macrolides specifically can be as high as 70% in some areas in some of the sites that they tested. And so this is why we do not do that, because definitely there's a high risk of failure to therapy. And so moxifloxacin has been the one that's sort of been attributed as the first line for matters of treatment. Now, the other thing that I alluded to is that San Francisco City Clinic does things a little bit different, and is that we do send for MGen testing on initial presentation for patients. This is actually a study that was published by Kelly Johnson on CID in 2022 that actually looked at the implementation of doxycycline for the basis of NGU treatment at City Clinic, as well as testing for MGen at first presentation of NGU at City Clinic. What's really interesting is that we did a pre and post analysis looking at the percentage of persistent NGU before the implementation of this particular subject in terms of doxycycline and testing, and then post. And we looked at the primary outcomes, which was the percent of persistent NGU clinic visits during the time period, as well as the secondary outcomes, which was looking at the percent of NGU, which were diagnosed with Mycoplasma genitalium. And what we found is that before the implementation, the percentage of persistent NGU was as high as 8%. But then after the implementation of using doxy for treatment of NGU and then testing at initial presentation, persistent NGU actually went down to 3%, and that was found to be statistically significant. The other things that are, and then that actually ultimately resulted in a 60% reduction in persistent NGU across the board at City Clinic. The other thing that was really interesting in this particular study is the number of cases that were attributed to MGen in the context of NGU. As you can see on the left side, right here, 82% of the cases before the implementation of this particular modality were actually attributed to nothing, meaning we didn't find an actual culprit when patients presented for initial NGU. However, that actually changed post-implementation and actually went down to 69%, which was also shown to be statistically significant. And one may wonder whether or not this 18% of cases of MGen that were found at initial presentation, because obviously we don't have the initials from the pre-analysis, given that we were not doing that before. One may wonder if Amgen was the reason why this actually went down. Now, there are some limitations to the study. Obviously, there was 2 interventions that were simultaneously done. And so it's hard to really decide whether doxycycline was the one thing, whether testing for Amgen early or both interventions were to blame. And also it was COVID-19. So perhaps people with persistent NGU were not coming in for testing within that 30-day window, which is what they define for persistent NGU in the study. Now, tetracycline resistance is something that we obviously worry about. And in terms of Amgen, we do know that it is highly susceptible to doxycycline in vitro, at least from several studies that have published this information. And in vivo, monotherapy with doxy is actually not very effective for Amgen. And so people wonder, why do we even use it then if it's not treating most of these cases? Some of the studies have actually published that 30% achievement of microbiologic cure is achieved with doxycycline after a 7-day regimen, and up to 59% for a 14-day regimen. But the one thing that is across the board known as far as doxycycline is that it does decrease the organism load in both cases. And so really the reason why doxycycline is used is not so much to achieve cure rates, but more so to decrease the organism load, which then allows for moxifloxacin to actually do its job, which is to eliminate the infection itself. Now, fluoroquinolone resistance. We obviously are worried about this as well, because as we know, and one of the things that we have learned from Amgen specifically, is that it is very susceptible to become resistant to antibiotics, and fluoroquinolones is one of them. As of now, however, we are getting pretty good response when it comes to moxifloxacin. But in this particular study, again, referencing back at looking at the asymptomatic individuals, there was some fluoroquinolone resistance that was found across all samples, which varies between 5% all the way up to 18%. So this is part of the reason why we also don't recommend screening asymptomatic individuals and treating people that may be asymptomatic, because we may be exposing them to antibiotics that they may not ultimately need and may increase the chance of resistance as well. Now, what about potential moxifloxacin resistance? If you do suspect that someone did fail moxifloxacin therapy, there are some agents that we do consider. And for the context of this, and always encourage people to reach out to us and obviously ask, because it's a little bit tricky and the evidence is not quite all there to really suggest what to use. However, the one thing that I would say, just for the purpose of sort of moving along so that Oliver can go back and talk about doxypep, I will focus on the minocycline segue, which is one of the recommendations that we actually do at City Clinic. Minocycline 14 days for 100 milligrams BID. Part of the reason for that is that it actually was found to be quite efficacious in a small study that was done. And so we do know that it's one of our only backups available in the US, because the other ones will have to require compassionate use, and some of them, or most of these here, are not actually available in the US. And the combination therapies of doxy and levofloxacin and moxifloxacin obviously is only effective in the absence of quinolone resistance. And then the last one, doxycycline instead of floxacin, was actually data that was published from a study in Australia that actually demonstrated that citalfloxacin does not have cross resistance when patients actually have fluoroquinolone resistance to levofloxacin and moxi. So I thought that was interesting, but again, not really available in the US and not something that we will recommend for treatment here. Now, some Amgen alternative therapies, as I alluded, will be for persistent infection, minocycline 100 milligrams orally BID for 14 days. There's also pristinamycin 1 gram 4 times daily for 10 days, but that itself requires compassionate use approval by the FDA. And then there's lefamulin, which currently is not available, and the dosage is to be determined for the context of this. So when in doubt, reach out to us. We'll be happy to actually guide you and assist you with anything that you might need. There's our number, but also e-consults is something that we have the capacity to do through CSFG. And we're driving really the point that retesting for persistent symptoms really should occur at least after 3 weeks after treatment, as we know that false positives are quite possible and can be present as well. Now, the last thing that I would like to sort of talk about is the big question that we also get at City Clinic, which is in the context of pregnancy and also for asymptomatic and symptomatic individuals. So I wanted to break it down for pregnancy and asymptomatic screenings, and then talk a little bit about symptomatic. For screening purposes of asymptomatic pregnant people, we actually do not recommend Amgen screening. Now, there is really no data on whether screening and treating asymptomatic infection in pregnancy really has any impact on birth outcomes, such as preterm labor or premature rupture of the membranes. And so we asked some of our experts at the California Prevention Training Center, because there's really no clear evidence or guidelines as to what we do in this context. And what they actually recommend is obviously doxy and moxy not recommended for pregnancy. We should not be using it. And it really should be down to a shared decision-making with the patients. If for whatever reason they present to your clinic with a positive screening for MGen in the context of being asymptomatic. However, what they do recommend is that if they have a male partner, they should be evaluated for symptoms such as urethritis. And if present, they should be tested and treated with doxy and moxy. And now, if for whatever reason the patient is very adamant about getting treatment for asymptomatic MGen, reasonable to use azithromycin 1 gram on day 1, and then followed by 500 milligrams 3 days for a total of 2.5 grams. But again, not really needed or recommended in the context of asymptomatic patients. Now, if postpartum MGen testing is positive still, then we recommend treating with doxy and moxy. And there is no need for test of cure post-treatment for these patients as well. Lastly, in the context of symptomatic screening, if a patient has persistent cervicitis and is found to be attributed for MGen without an alternative explanation, again, the recommendation would be to do azithromycin 1 grams on day 1, and then 500 milligrams for 3 days for a total of 2.5 grams. And after treatment completion, if the symptoms resolve, then there is no need for test of cure. And if the patient has a male partner, test and treat with doxy and moxy if the test is positive to avoid potential reinfection of the patient. But again, this is all pure guidance from the California Prevention Training Center. There's no specific guidelines that are depicted from the CDC, specifically in the context of pregnancy and symptomatic screening or treatment of MGen. It's also important to note that this organism has been added to the CDC watch list in 2019, given the rise in resistance to macrolides and the upcoming and the known rise to fluoroquinolones as we speak. We know that it very quickly develops antibiotic resistance with increasing prevalence. And so again, really taking in consideration whether or not to treat someone that has no symptoms or even testing for that matter. But if someone that has actual urethritis symptoms on acute presentation, definitely something to be considered and something to at least entertain as a potential diagnosis. So some takeaways before I wrap up here. Consider testing for MGen in all patients that are presenting with urethritis or cervicitis on initial presentation. Remember that macrolide resistance is high and climbing, and therefore we do recommend doxy 100 milligrams twice a day for 7 days, followed by moxy 400 milligrams daily for the next 7 days for a total of 14-day treatment. Also remember that there's a high level of false positives when we retest at less than 3 weeks. So it's really, really important that you wait at least those 21 days, if not longer, prior to retesting if patients have persistent symptoms. And under no circumstances, testing asymptomatic patients for MGen, and that also includes pregnant patients as well. And for context to MGen, remember to test and wait prior to treatment. At City Clinic, we actually do not recommend treating. We actually want to test, and if positive, then treat at that point. And again, it is okay to have that 7 days between treatment. It is acceptable it's an acceptable window between doxy and moxy, but anything greater than 7 days will warrant to restart the full cycle over again in order to ensure that we achieve a decreased burden of bacteria in order to be able to actually successfully treat the infection. And lastly, I would like to acknowledge my colleagues as well as the San Francisco City Clinic staff who day and night are obviously working really hard in doing this work. And so here's my email if any questions, and also our website. Thank you so much.
Thank you so much, Franco. For the sake of time, we are actually going to take questions for both Franco and Oliver at the end. I'll just share one comment from Kelly Johnson in the chat that for our audience in person so that you can see. She mentions that another resource for STI consultation is stdccn.org, which has a portal for STI questions run by the California Training Center at UCSF. And Oliver, will let you take it away.
Yeah. Cool. All right. Thanks everybody for being here in person and out there in TV land. Thank you, Franco, for that awesome summary on MGen. So I'm going to talk about the early implementation, uptake, and effectiveness of DoxyPEP at San Francisco City Clinic. I realize that many people sitting here and online know a lot about DoxyPEP and ran and participated in the conduct of the DoxyPEP study. So please don't be shy. Feel free to correct me or add additional information. I'm also going to assume that most people listening to this talk are familiar with the basics of DoxyPEP. So I'm including some slides that have the basics, but I'm not going to dwell on those. Okay. So this is my disclaimer. The views expressed here are mine and not necessarily those of the health department. If you don't like what I say, blame me, don't blame the health department. Okay, so I'm really going to focus on DoxyPEP implementation here, how to initiate it, how we initiate it at City Clinic, what is the meaning of eligibility, which is a word I really can't stand, how we counsel patients about what we do know and what we don't know about DoxyPEP before they start it, how we do the follow-up. We have a very counselor-run, provider-light, scalable DoxyPEP program. Some information, some early data that we collected on how people, uptake of DoxyPEP and how they use it, and then some early effectiveness data from City Clinic and Citywide. Okay, and to focus everyone, here's a case. So 24-year-old HIV negative self-identified gay man on HIV PrEP through a mail order service. He comes to you and says, I don't want to get an STD. No one wants to use a condom with me. This guy told me I should take Doxy PrEP. Do you think I should take it? I'm not being snarky here with the Doxy PrEP comment. We see this all the time. That one little R gets people very confused. And they're so used to HIV PrEP that they think Doxy PrEP is actually Doxy PrEP. So anyway, we do a sexual history, or you do a sexual history. He's had 6 male partners in the last 3 months. He has receptive and insertive anal sex. He gives and receives fellatio. His last STI screening was a little far in the past. It was done 9 months ago. Urine, throat, and rectal gonorrhea and chlamydia gnats were negative. HIV was negative, and his RPR was non-reactive. He did have pharyngeal gonorrhea 2 years ago. So what would you tell him about DoxyPEP? 1, it's DoxyPEP, PEP. There's no R. You take it after condomless oral or anal sex, not every day, unless that's how often you need it. Or, well, you haven't had an STI in the last year, so I don't think the benefits outweigh the risks, especially the risks of developing drug-resistant bacteria and harming your gut microbiome. And he's like, gut microbiome? What's my gut microbiome? And then 3, you should definitely take it. You're just the kind of person they studied, and it will lower your risk of gonorrhea by 65%. Or some combination of these, 1 and 3 or 1 and 2. Okay, so what do people think? Okay, everyone agree, well, not everyone, 2/3 of people said it's PEP, not PrEP. Thank you. Interesting. Okay. So some people are worried about the risks outweighing the benefits, particularly antimicrobial resistance. But then some people definitely think you should take it. Okay, all right. So that's a very interesting split, and that's why we're going to talk about this. This is one of the great unknowns. Okay, so this is kind of the history of the development of DoxyPEP over the years, and it actually started with Doxy PrEP down in Los Angeles. And just so to get everyone on the same page, DoxyPEP consists of 200 milligrams of doxycycline taken 24 to 72 hours after condomless oral or anal sex. And it was found in the DoxyPEP study run by Dr. Lukemeyer here and some other colleagues to decrease the overall quarterly incidence of gonorrhea, chlamydia, and syphilis by 65% in people who were living with HIV and people who were not living with HIV but were on HIV PrEP. And these were all cis men and trans women. And to be included in the study, they had to have sex with men, they had to have at least 1 episode of gonorrhea, chlamydia, or syphilis in the prior year, and they had to have condomless sex with at least 1 person. So that's kind of where we're starting from. So how do we counsel patients about DoxyPEP when they come to clinic? Well, we do shared decision-making between the patient and the provider. We do a careful sexual history, and we help people get what we hope is an accurate sense of their risk. And we find that people often overestimate and underestimate their risk of STIs and HIV. We review how to use DoxyPEP. We acknowledge the knowns and the unknowns. We go over the dosing, the side effects, and we also embed this in a comprehensive package of sexual health services. And on the left, you see our DoxyPEP handout, which we found is helpful for patients and providers alike. So what are the knowns that we talk about? So we talk about how to use DoxyPEP. We talk briefly about the study. We say how the study was conducted, who was in it. I'm just going to focus on what we really drill down on, which is the inclusion criteria for being in the study. And then we talk about the three main takeaways. So overall, risk in this group of people was reduced by 65% versus standard of care. That the decrease in gonorrhea was roughly 50%, and that the decreases in chlamydia and syphilis were on the 80 to 90% level. So a little bit less effective against gonorrhea, quite effective against chlamydia and syphilis. All right, those are the knowns. What are the unknowns? Well, what about doxypep in people who are assigned female sex at birth? We do have people assigned female sex at birth, both cisgender women and trans men who are interested in doxypep. And so we will talk about the DPEP trial at a 30,000 foot view level and say that in a randomized controlled trial, it was not found to be effective at STI prevention. But then we will also say it looks more and more like this was a question of adherence rather than any pharmacokinetic effect. At various sites, we know that doxycycline works perfectly well to treat chlamydia and syphilis in people who are assigned female sex at birth. Okay, so that brings up this whole question of eligibility, or who, I like to think of it more as who benefits most from doxypep. And in the middle of this continuum, which was, this diagram is from Julie Dombrowski up in Seattle, who was one of the doxypep investigators. In the middle, you have study eligibility for the doxypep study. And then you have off to the left, you have a more restrictive approach. So the goal of which is to maximize the benefit to risk ratio, the risks being potential side effects, microbiome effects, and antibiotic resistance, to minimize excess antibiotic use. But the drawbacks to this are it's more complex to identify candidates for doxypep. You have to do more fact finding, and it will reduce the reach and impact. And then over on the right, you have broader use, more liberal use than the study eligibility. It will meet patient demand because there have been a number of studies that show that people are very interested in using doxypep. It's less stigmatizing. It's a larger group of people. You will probably reduce the total absolute number of STIs that people get with the cost of distributing a lot more doxypep out there. So this is kind of the continuum that people have in mind when they're deciding whether they're going to offer doxypep in their clinic or in their program. And this was a really interesting study done at the Fenway Clinic in Boston by Michael Traeger and Ken Mayer. It's a modeling study looking at how you could target delivery of doxypep to maximize efficiency, and efficiency was defined as the percent of STIs prevented over the percent of individuals prescribed. And you can see, do I have a pointer? I'm just gonna use my finger. Okay, so basically, you achieve maximal efficiency if you restrict doxypep use to people who have a history of STI, at the expense of a smaller number of people treated and a smaller absolute risk in infections prevented. Okay, so people have interpreted these data in all sorts of ways. And so this is kind of a buffet of the various guidelines for doxypep use in a number of countries around the world. So you can see that the CDC draft recommendations are consider for MSM and trans women with at least one STI in the past year. So they really hone in on this history of STI with insufficient evidence for other groups. And I can tell you they are apparently on the verge of actually releasing their final guidelines in the MMWR. So it'll be very interesting to see what how CDC puts their nickel down. Over on the more restrictive side, you have Public Health England. They do not endorse doxypep and they're reevaluating that. The Germans feel this should be done only on a case-by-case basis and reserved for specific individuals. way over here on the right, we have California Department of Public Health. They're like, yeehaw, go for it. Offer to all non-pregnant individuals at increased risk for bacterial STIs and those requesting DoxyPEP. That was very interesting to read when that came out. And then we are slightly less gung-ho, but pretty gung-ho at City Clinic. All right, so there were no guidelines in October of 2022. And so at the health department, we decided we needed some guidelines in San Francisco because we knew people were using DoxyPEP. It's a very early adopter city. And we didn't want there to be doxy anarchy out there. So these were our initial recommendations. So tier 1 was basically recommend DoxyPEP to anyone who would have met study criteria. Okay. Tier 2 was people, well, tier 2 said basically offer DoxyPEP using shared decision-making to cis men, trans men, and trans women who report having multiple partners in the prior year, even if they haven't had an STI. Okay. So those are people who would have screened out of the study. And then for cis women, we said DoxyPEP is not recommended based on the currently available evidence from the Kenya DPEP study. And that was before Janelle Stewart released the interesting hair data that Dr. Gandhi and some other people around here participated in, showing that adherence may have been driving the lack of efficacy in that trial. So once that was released, and with some time and the opportunity to marinate on the subject of DoxyPEP in cisgender women, and remembering that we focus on MSM and trans women in San Francisco a lot in our HIV and in our STI prevention and treatment, but the highest rates of chlamydia everywhere are in people assigned female sex at birth, particularly young women. And so there's something very galling about not offering DoxyPEP to the people who are at highest risk of chlamydia. So these are kind of where we're going with group 3 here. So these haven't been released yet, but this is kind of what we're thinking of saying. Results from the Kenya DPEP study found that DoxyPEP was not effective at preventing STIs among cis women. We have to acknowledge that study. Drug level data suggests that this may have been due to low adherence to DoxyPEP. Providers can consider offering it to cis women on a case-by-case basis, for example, to women with a history of syphilis or women who exchange sex for money or drugs. If prescribing DoxyPEP to cis women, providers should counsel patients about the lack of efficacy data, reinforce the importance of adherence, conduct pregnancy testing, and advise not to use when pregnant. So we're trying to put, in the absence of RCT data showing that it works, we're trying to give some parameters to use when considering DoxyPEP in cis women. For trans men at City Clinic, we have a small number. We see a small number of trans men. They tend to be at very high risk of bacterial STIs. So we feel pretty comfortable with the risk-benefit ratio of giving DoxyPEP to trans men, our trans men at our STI clinic. Okay, we don't want to replicate in DoxyPEP expansion what happened in the early days of HIV PrEP expansion, and restrict DoxyPEP such that the people who need it most aren't getting it. And I think everyone is familiar with the PrEP need to use ratio. We don't want a big need to use ratio to open up for DoxyPEP. So these are citywide data from the Getting to Zero Consortium, and this was presented by Stephanie Cohen at Croy last month, looking at disparities in uptake by race ethnicity at 2 sexual health clinics, City Clinic and Magnet, and 1 HIV care clinic just about 200 yards away. And you can see that there are some disparities. Rates of uptake among Black African Americans are a little bit lower than average, which is the red line, at all 3 sites. But if you look at all of the uptake percentage, there's not that much difference. There is disparity, but the overall uptake is in around the 20 and low 20% rate, which is encouraging. Okay, so another unknown, what about antimicrobial resistance? So for syphilis and chlamydia, I really don't think that this is an issue. We've been using doxycycline to treat syphilis and chlamydia for decades, and resistance has not emerged. There have maybe treatment failure occasionally, but that's not due to resistance. Gonorrhea is another story. We know that there's variable rates of tetracycline resistance in circulating strains of gonorrhea. It really varies geographically, 20 to 30% in the US by CDC surveillance data, 90% in France, where a lot of the doxypep trials have been conducted, and about 100% in the area, in the regions of Kenya where the DPEP trial was conducted. And as many people have said, doxypep's probably not going to be the answer for gonorrhea prevention. It may be some doxypep, some other stuff, particularly the development of more gonorrhea-specific vaccines. But the real concern is, will intermittent doxycycline use drive increased tetracycline resistance in other bacteria, non-STI related bacteria? And also, will that be accompanied by the development of resistance to other antimicrobials in those organisms? And we can't discuss the whole broad subject of antimicrobial resistance and tetracycline and doxypep. That's at least an hour-long talk, and I'm not the person to give it. But I can talk a little bit about some of what we know so far from studies of resistance in doxypep trial. So one question is, does doxypep drive increased tetracycline resistance in gonorrhea? And we can't say that from the data we have so far. There were a few more cases of doxypep failure in gonorrhea in the doxypep trial, but that's probably because of pre-existing resistance, not resistance that developed while people were on doxypep. Another question is, what is the effect of doxypep on carriage of Staph aureus? We use doxycycline to treat staph, particularly MRSA. And in the doxypep study, if you were randomized to the doxypep arm, there was a 14% absolute reduction in staph colonization, and a small absolute increase in doxycycline resistance compared to baseline at 6 months. MRSA prevalence was low in both arms, and it was unchanged if you were in the doxypep arm. So that's encouraging, small numbers, but encouraging. And then the other question is, what about these commensal non-pathogenic Neisseria species in the pharynx? We know, or we think, that a lot of resistance acquisition occurs in the pharynx through these commensal Neisseria species. And Neisseria are very gregarious, sort of like gonorrhea. And they tend to acquire and share their genes. Luckily, it doesn't appear that that was an issue in the doxypep trial. 2/3 of isolates of non-pathogenic Neisseria species had pre-existing resistance. It's already a problem. It doesn't seem to have been affected by doxypep. All right, numbers are small. Preliminary data are encouraging. I think really to answer these questions, we're going to have to do much larger scale surveillance, particularly in STI clinics, to look at antimicrobial resistance using a broad range of antimicrobials in people who are on doxypep and not doxypep. And there is national infrastructure to start to be able to do this, kind of piggybacking on the gonorrhea isolate surveillance programs. All right, so this was a super interesting poster at CROI. How am I doing on time? I'm doing okay. This is a super interesting poster at CROI by Victoria Chu, who is a PEDS ID fellow at UCSF. So this was looking at the impact of doxy as post-exposure prophylaxis on the gut microbiome and antimicrobial, the presence of antimicrobial genes and gene expression. And these were comparing people at 0 and 6 months in the doxypep trial. In 100 participants, 100 were in the DPEP arm, 50 were in the standard of care arm. They had swabs at baseline and at 6 months. And she and her team did metagenomic sequencing to look at antimicrobial resistance genes, looking at the reservoir, the presence of these genes, namely the DNA, and gene expression, looking at RNA. And what they found was there was plenty of tetracycline antimicrobial resistance mutations at baseline and at follow-up in both arms. Gene expression did increase in the doxypep group versus the standard of care group. But luckily, gene expression of resistance to other antimicrobials did not. That doesn't put the question to rest, but it is some early, preliminary, somewhat encouraging data. And I'm going to leave it at that. I'm not going to draw any further conclusions. And there was no change in the gut microbiome diversity by study arm. I encourage people to look at this poster. It's really, really nicely done if you want to look at the details. All right, so how do we do DoxyPEP at City Clinic? We have a very clinician light, task shifting heavy program. So people can get DoxyPEP in two different ways. So in blue refers to clinicians, orange refers to our biomedical prevention counselors, the folks who get people on PEP, PrEP, and DoxyPEP. So if you are seeing a clinician at City Clinic for a sexual health visit, we will screen you, and then through shared decision making, if the decision is to go ahead with DoxyPEP, you get gonorrhea, chlamydia, RPR, HIV, AST, and ALT screening, and the clinician will notify the biomedical prevention team that you want DoxyPEP. I really hope that the CDC guidelines drop the AST, ALT testing at baseline and annually. We do it because we're being cautious, and we ask Franco what it's like to follow up on all the slightly positive AST and ALTs. It's a lot of work for zero benefit. So then after nursing draws the labs, the BMP counselor will review the DoxyPEP basics and then penned an order for DoxyPEP for the clinician to sign. We have a particular SIG for our DoxyPEP order to distinguish doxycycline given for PEP from other reasons, and that allows us to track our DoxyPEP users. So it's doxycycline 200 milligrams PO Q24 hours PRN. And they will pen an order if the patient is uninsured for clinic dispensed doxycycline. One of the beauties of Doxy is it's so cheap, we can afford to buy it and give it to people who don't have insurance. So they'll get 100 tabs, no refills. If the person has insurance, public or private, they'll pen an e-prescription to the pharmacy for 60 and no refills. And then to follow up, patients will call the BMP line if they need a refill, and the counselor will pen the order for a clinician to sign. And then every 3 months, ideally, they will come in for STI and HIV testing. And then we employ some very standard DoxyPEP use questions in our EMR that I'll go into in a minute. And that box is stippled because the clinicians do it and the counselors do it, depending on who's seeing the patient. The other way to get DoxyPEP is if you're already in our PrEP program, you almost by definition meet the DoxyPEP would be good for you, probably. So every PrEP patient is screened for DoxyPEP interest and eligibility at their quarterly telephone follow-ups with the biomedical prevention team. And then they enter the pathway through a clinician visit. The clinicians are always there when DoxyPEP is initiated, but really follow-up is done by the BMP team. So these are our DoxyPEP use questions, and these are actually available network-wide. So there's guidance on whom to ask. So ask these questions of City Clinic DoxyPEP patients at all visits, all patients eligible for DoxyPEP, so MSM, trans persons with chlamydia, gonorrhea, or syphilis, or 2 or more partners in the last 12 months, and any MSM or trans person at the time of STI treatment or diagnosis. And then the questions are, have you used DoxyPEP in the last 3 months? Yes or no? If you're getting DoxyPEP, where are you getting it from? Because we know that people are sharing their DoxyPEP. That's not really a bad thing. We just are very interested in finding out more about that. Was your most recent condomless sex, oral, anal, or vaginal covered by DoxyPEP, yes or no? And then more specific adherence questions. And we realized that the denominator shouldn't be number of times you used it or number of partners, it's the number of days that you used it. So on how many days in the last 30 did you take DoxyPEP? And then on how many days in the last 30 did you have condomless sex and not take DoxyPEP within 3 days? So those are the questions that we're using. Okay, so what have we found in the early implementation of DoxyPEP? And I have 8 minutes. Okay, so this was data that we presented at the ISS TDR meeting last summer. And this was looking at uptake of DoxyPEP in our PrEP patients because they are systematically asked about it. So you could really look at the question of uptake. And in tier 1, so people who would have met study criteria, 74% of folks agreed to start DoxyPEP. In tier 2, so people with 2 or more partners but no STI in the prior year, 60%. So high uptake, a little less high than tier 1. And then we had a tier 0, which were people who didn't meet either tier 1 or tier 2, but through shared decision making, it was decided that they might benefit, and uptake was about 29% in those folks. And this was looking at 762 people, and we started about 850 people in the first 6 months of DoxyPEP at City Clinic, and that was starting at the very beginning of November of 2022. So we wanted to know what was associated with uptake. It was very interesting what was not associated with uptake. So age, sex or gender, or race ethnicity, those things were not associated with uptake. What was really associated with uptake was the number of partners in the previous 3 months, and that was true in tier 1 and tier 2. So how did people use DoxyPEP? Uptake was high when it was offered, 89% overall, but they didn't use it at every visit. So about 70% of people reported using it at their most recent episode of condomless sex. They reported using it between 4 and 6 times a month, which really overlaid quite nicely on the DoxyPEP study data. But they also didn't use it at about 3 sexual encounters in the last 30 days. So there's some picking and choosing. People are kind of using their spidey sense who they're going to use their DoxyPEP with. And what we often hear, and this is totally anecdotally, is I don't use it with my partner. I do use it with new partners, and I use it with someone I feel kind of sketchy about, whatever they mean by sketchy. Okay, so then we also wanted to know, is it working? I mean, we have the randomized controlled trial data, we have efficacy data, but what about implementation, the outcome of implementation at an STI clinic? So at CROI, we presented this poster. So this is looking at effectiveness in men who have sex with men and trans women on PrEP, again, looking at that particular population. And we used that population because we had really good and equivalent follow-up data. We had basically equivalent follow-up time. So it was a more accurate way of looking at differences. And the question was, what's the change in STI positivity among users versus non-users? And so we found 506 people who had a visit before and after, in the year before and the year after we started implementing DoxyPEP. And that was in November, the beginning of November 2022. Okay. And the comparison was STI positivity in DoxyPEP users before and after they individually started DoxyPEP versus positivity in DoxyPEP non-users before and after the implementation date of the program. Okay. And what we found was baseline chlamydia and gonorrhea positivity was higher in users than non-users, which is what we thought and which is what we want to see, actually. Means the right people are getting it. We found that among DoxyPEP users, chlamydia declined 90%, and this was statistically significant. And early syphilis declined 56%, and this was statistically significant pre to post. What we also found, though, was that there was a numerical decrease in rates in positivity of all 3 STIs in the non-users over time. This is not a data integrity problem. This is actually, we're seeing this around California. We're seeing this in other countries. I just talked to Philip Chan in Providence. He just analyzed their data. They saw a slight decrease in rates. No one knows exactly why this is happening. Everyone wants to think that this is a community effect of more people being on DoxyPEP and less transmission going on. And I'm going to show you some data in a sec that might support that. At any rate, the question was, if you see a decrease in all 3 STIs in people not taking DoxyPEP, what about the decrease in people who are taking DoxyPEP? We found that for chlamydia, it was significantly higher than among those not taking DoxyPEP. So if you look at it, we did a difference of differences analysis, and that was a real difference. For syphilis, it was almost significant, but not quite, and that's probably due to low syphilis numbers. For gonorrhea, there was no effect of DoxyPEP in our City Clinic study. All right, so we're not the only ones in San Francisco who did this. Over at Magnet, Hyman Scott did a very similar analysis, although Matt Spinelli was involved in that, and somewhat different in technique. They did an interrupted time series as well as looking at absolute differences. They also found similar findings. So 67% decrease in chlamydia, 78% decrease in syphilis. Those were also statistically significant. Not much of a change in gonorrhea. So then what about citywide data? So Maddie Sankaran, who's an epidemiologist in the department, did an interrupted time series looking at, and this is ecological data, looking at differences in chlamydia, gonorrhea, and syphilis rates pre and post the release of city guidelines, and found significant decreases in both chlamydia and syphilis compared to what was modeled, compared to what should have happened based on pre-doxypep rates. So that's in the blue. No effect for chlamydia. So that is very encouraging citywide data. Those are the first citywide data looking at effective doxypep outside of a clinic. Okay, just 1 minute. Oh dear. So I'm going to skip the rest of the case, which is what do you do with contacts to STI who are taking doxypep? The answer is we don't know, but we are allowing some people to wait, test and wait before getting treatment. But I want to leave time for questions, and that's it. All right.
Thank you, Dr. Bacon, Dr. Chevalier. I know that there are a lot of great questions, so I just wanted to leave a couple minutes as we see for. I saw Dr. Gandhi's hand up.
Hey, that was such great talks by both of you. My question is about the DPEP Kenya study. If you get a consent that says pregnancy is doxy could like make your child's teeth brown and hurt their bones, and like it's Franco, you said it was contraindicated in pregnancy, even though we use it if we need to. Then don't you think that really cut down on taking it, given that they were young women and there was pregnancy rates? And what is the idea, what's going on at your level, the CDC level, to like say, okay, let's stop it. Let's maybe say it's safe in pregnancy and we can stop this concern.
I am so glad you asked that question. Oh, there's a mic, right. I'm so glad you asked that question. I haven't heard anyone ask that about the DPEP trial. If I were looking at that consent form, I would worry about that too. I think I'm just going to say, speaking for City Clinic, we're very vexed by the recommendation against doxycycline in pregnancy and in children. For tetracycline, like pure tetracycline, yes, teeth, bones problem. It has not actually been found to be a problem using doxycycline, and yet the black box warning remains. And I really hope that gets changed. And it may, and I have no idea, but I can see it being re-examined in the context of the potential benefits for doxycycline for STI prevention in women. I'm just going to leave it at that.
That's great. I'm going to ask one great question from the chat and then I'll from you. So one thing that's come up for my patients is that having a supply of doxy on hand is allowing them to self-treat other infections. My throat was sore, so I started taking doxy for the last week and a half. Has this come up for you all, and how are you counseling people about this?
Yes, it comes up all the time. And I think the general guidance that we give our patients at City Clinic is generally to try at all possible to not use their doxypep as a tool to treat a potential exposure to, i.e. chlamydia, or if they have some sort of sore throat, whatever it may be, but rather come in, get tested. And we kind of talk about it not just in the context of like, this is just strictly for doxypep use, but also in the context of like, you really want to know exactly what's going on. And also making sure that you completely understand and we understand the full picture so that things don't get cloudy and misinterpreted. And so that's really our messaging. It should be the messaging that we should be getting across, that people should use doxypep specifically for what it's given for, and then everything else come in and get checked before you try to take it for the purpose of chlamydia or something else.
Okay, I'll do quick questions related to Monica's doxy versus a throw for MGen, and given the pregnancy thing that we don't actually think doxy is teratogenic. What do you guys think about doxy versus a throw for MGen?
In people who are pregnant? we don't do it because the medical legal risk, and also we don't want there to be a bad outcome. I highly doubt there would be a bad outcome, but I think the counseling is tricky and the risk is high. The medical legal risk is high. Quinolones, I would not give quinolones to a pregnant person. So in a sense, what you would be recommending would be doxycythro, not doxymoxy. But until the medical legal questions are settled, I think, the Hail Mary with a high dose extended azithro is the way to go. In Australia, they have macrolide resistance testing that's coupled with their NAT testing. So they can determine whether someone's MGen is going to be susceptible to a macrolide. We don't have that in the US yet. Although given rates of macrolide resistance that we've seen on sort of nationwide studies, it probably would be effective in a small minority of cases.
Thank you both so much. We have turnover for CFAR, but let's give them another round of applause. Thank you.